Good evening, everyone. Thank you so much for joining us tonight for our latest Medicine for Members event. My name is Tatiana Votinova. I am a Royal Free London elected patient governor. These events are organized and shared by our Council of Governors. Our Medicine for Members events focus on topics that we know are more important to you, our members. They give you the opportunity to hear more about the Royal Free London services. So for tonight, our topic is Leading the Fight Against Cancer, the groundbreaking research at the Royal Free London. So during tonight's event, you will hear from Dr. Alexa Childs, Principal Clinical Research Fellow and Honorary Consultant in Oncology, and Dr. Gloria Aidu-Maika, Clinical Research Fellow, about how cutting-edge research is transforming cancer care and treatment. So as everyone of you may know, cancer is on the rise right now. It is estimated that 3.5 million people in UK are living with the disease, and by 2040, one person will be diagnosed with cancer every minute, when new cases are expected to rise to 500,000 a year. As one of the largest cancer care providers in the NHS, the Royal Free London is already at the heart of tackling this devastating disease. Improving care for those who, with cancer forms a key pillar of our 5-year clinical vision, and our commitment goes beyond treatment, with research at the forefront of our approach. So tonight, the groundbreaking research taking place in our clinical research facility will be showcased to you. This includes a study looking at whether giving new immunotherapy treatments to patients with early-stage liver cancer will help prevent the disease returning in the future. You will also gain an insight into the new therapies and treatments that have been made available to our patients through the research. And I would like to take this opportunity to thank the Royal Free Charity for their pivotal role in making our clinical research facility a reality by providing the vital startup funding. More broadly, the charity helps us drive the research across the trust in a variety of impactful ways, such as they invested £60 million to deliver the Pierce Building, which houses the Institute of Immunity and Transplantation. They provided funding for early-stage research, which helps researchers take that crucial first step and build the evidence they need to attract major investment. And they're helping us nurture tomorrow's research leaders by funding PhDs and master's degrees for the next generations of scientists and nurses. This extraordinary backing is made possible thanks to the generosity of their supporters. If you would like to learn more about getting involved, please visit the charity's website, which is on the screen now. And before I hand to our presenters, there are just a few housekeeping points that I'd like you to be aware of. So first, to ensure the events run smoothly, you're set up to view only. This means your cameras have been disabled and you have been on mute. If anyone experiences connection or visual problems, a recording of the meeting will be available in the coming days, and a link to the recording will be sent out to all members after the event. And again, if anyone who has joined us this evening is not a member yet, you can always sign up on our website, and the link is in the chat now. So today there will be a Q&A session after our speakers have presented. We have had several questions submitted in advance, but please ask any questions you may have through the Q&A chat function on the right-hand side of your screen. We will do our best to answer all the questions you have today. Just to let you know, our speakers will not be able to answer any specific questions about your or anyone else's care or treatment. And if your question is not answered, please send it to the membership inbox, which is on the screen now. And if you would like to contact the Council of Governors with any queries, concerns, or any comments, please do so via the Governor inbox, which is on the screen now. And again, I hope you will enjoy the event. Thank you so much for joining us today. And I'll hand over to our first speaker, Dr. Alexa Childs.
Hi, so thank you so much for joining. My name is Alexa Childs, and I am a medical oncology consultant. I work looking after patients with HPV tumours, so that's tumours of the liver, the biliary tract and the pancreas, but also a lot of my work is involved in looking after patients who are treated as part of clinical trials, and particularly within the CRF. So it's a real pleasure to be here today, and it's actually very exciting. We've got so much to say to you that I have to talk fairly quickly. So if we start with the slides, this is a little bit just of background information in terms of the scale of the problem that we are dealing with here. So as has already been referred to, currently in the UK, every 2 minutes, someone is diagnosed with cancer. And actually over half of all patients now who are under 65 years in age will be diagnosed with cancer at some point in their lifetime. So it's a huge and rising problem. If we think more locally within London and within north central London, the number of people with cancer is growing, and cancer is the number 2 cause of death within London and the leading cause of premature death in those less than 75 years of age. The Royal Free London is actually the largest provider of cancer services in London, and actually one of the largest providers within the whole of the UK. And the number of referrals we are seeing is rising. So it's risen by 10,000 since 2019, and we receive over 60,000 new suspected cancer referrals per year. In keeping with that, over half of these kind of urgent 2-week waits query cancer referrals within the whole of north central London are coming to the Royal Free Hospital. So partly reflected in that, we know that there are more people with cancer. Gratefully, a lot of people are living longer with cancer. We have new treatments, we have more expensive treatments, and all of that contributes to the fact that now roughly a quarter of the whole of the Royal Free's budget is spent on cancer care each year. So due to that, we've already heard that cancer has been identified as one of 3 priority areas within the Royal Free's Trust clinical strategy, and that's further demonstrated as well by future plans for a cancer centre. So very briefly, why is cancer research important to the Royal Free? So ultimately, the most important thing has obviously got to be patient outcomes. By partaking in clinical research, we are getting early access to the treatments of the future. We know that patients who are treated within research active hospitals have better outcomes, and that's not just patients who are actually taking part in clinical trials. Even those being treated outside of clinical trials have better outcomes if they are treated at a hospital that has a significant research output. Moving on, it is a boost. Firstly, it's in keeping with our trust values. You can already see at the bottom of our slide here, our aim is to provide world-class expertise, but local care. So really, we want to be able to ensure that our local patient population is able to access cutting-edge technologies. And it is important in terms of boosting our reputation as well across the UK and also internationally. One of the reasons that's important is in terms of our workforce. It's actually very well documented now that staff who are working research active hospitals have a much improved job satisfaction, and we're able to retain those staff. That's important. It's important to be able to attract those academic staff who are the high-flying achievers and to be able to retain them with us at the Royal Free. So taking part in cancer research is important for those reasons. We already have multiple existing strengths here at the Royal Free. We have specialist multidisciplinary teams looking after patients with primary liver cancer, for which we're a tertiary referral centre, and pancreas and biliary tract cancers, for which we are also the surgical centre. We are the largest kidney cancer centre within the UK, and we were the first European neuroendocrine centre as well. So we have areas of existing strength that we need to build on, and that we have access to patient populations where we're in a unique position to be able to recruit to these studies. We also have other areas of strength, such as our nuclear medicine department, where we have a fairly unique ability to run nuclear medicine studies looking at theranostics and radio-labelled treatments. And again, we have referred to the fact that we have a very broad patient population covering a vast area. This is a diverse patient population, even more so now with the takeover of North Middlesex Hospital. It's therefore our responsibility to ensure that our diverse patient population have access to clinical trials. And not just our responsibility to these patients, because if these patients are not included in clinical trials, then we can never be sure if these studies or the results of these studies are applicable to them. And potentially in the future, these patients may miss out on treatments that may have been effective for them. So it's very important that we have this diverse patient population, that we make the most of that in terms of inclusion in clinical trials. And then finally, financial. So actually, patients who are treated in clinical trials, we're reducing the cost to our healthcare setting. And actually, at the moment, we all know that it is a economically tight time. Also, these studies have the potential to bring in income that can be then reinvested in our cancer trials and our clinical services. So that is also an important reason to be involved. So all of those things really highlight why cancer research is important, and we've taken some significant steps in really going down that path, both with the building of the NIHR CRF, which I'm going to discuss in a bit more detail now, the appointment of 3 academic medical oncologists, of which I'm one, our plans for the cancer and our plans for the cancer centre as well. So just briefly, in terms of recapping, so what I'm saying today makes a little bit more sense. These are the general phases of clinical trials. So when you have a first idea for a new therapy, you may have some preclinical information that suggests this may be a good treatment, but it's never been tested in a human before. So the phase 1 is really that very first time we're looking at a new drug or treatment in the patient population. So it's the first time something's been tested in a human. Because of that, there is an obvious focus on the safety of the treatment, on identifying the correct dose of that treatment, and on establishing what the side effects may be. We have a small number of patients involved in those studies, although they may be recruited globally, and they take place over several months to roughly a year, so fairly short studies. Once the study has gone through that initial phase 1 and you've established the dose and the likely side effect profile, it moves into phase 2. That's looking potentially at a patient population that may be more selected, and you're looking to see that first signs of efficacy. So do we think that this is actually having a clinical benefit to those patients, at the same time as assessing for safety? And that recruits a larger number of people, and the study runs over a longer period of time. If that is positive and we have initial signs of efficacy, then that moves into the phase 3. So this is the area where more patients are used to being treated, where we are comparing that new treatment to the standard of care. So often these studies will be randomized. So a patient will go on to the study not knowing whether they're going to receive the usual best treatment that we have or the new treatment. So we're comparing the two to see which is more effective or if they are equivalent. That involves multiple hundreds of patients and takes place over multiple years. And it has to go through all of those stages in order to finally make it out the other side as an approved treatment. And multiple treatments do not make it the whole way through that process. So introducing now the NIHR Clinical Research Facility. So as has already been mentioned, we are indebted to the Royal Free Charity, really, in terms of providing the initial funding to set up this facility. What is a clinical research facility? So essentially it's an area with specific facilities, a purpose-built area to partake and conduct early phase studies. So referring back to my previous slide, this is really looking at phase 1 or phase 2 studies, so potentially the first time that new drugs are being tested in patients, or in a slightly later stage where we're looking at maybe optimizing doses and looking at efficacy in a slightly larger group of patients. And this is needed because these studies are potentially higher risk studies. We don't know everything about the potential side effects profile, and so we need purpose-built facilities to be able to run these clinical trials. Following on from the Royal Free Charity funding, we were awarded almost 5 million by the National Institute for Health and Care Research to support the research and the growing of this facility between 2022 and 2027. And we don't obviously work in isolation, so we're part of the UCL Experimental Cancer Medicine Centre. So there are multiple experimental cancer medicine centres, or ECMCs, across the UK, who work collaboratively to organise and efficiently run early phase clinical trials. And we're part of the UCL ECMC alongside the UCLH phase 1 facility. And as part of this, Royal Free Charity was also instrumental in gaining funding towards 3 academic oncology appointments. I am one of those, and I have 2 other colleagues, Rob Goldstein and Tony Runnan, who are appointed as well. And we have roles looking after patients with specific tumour types, but also a dedicated portion of our time to try and increase the number of trials that we're running in the CRF and really make sure that we have a portfolio of studies that is applicable to our diverse patient population. So how does the CRF support research? So firstly, as I said, it's focused on early phase studies. For early phase studies, because the side effect profile may not really be known, we need people who are and facilities that are specifically able to look after those patients that may be undertaking a potentially higher risk treatment. There's increased legislation, admin, regulatory work associated with these studies. As you can imagine, there's very close reporting of the side effects that patients are having, and an increased number of trial visits. Patients as well may be having additional procedures that may not normally be having a standard of care, so additional blood tests or potentially biopsies. And for this, we need purpose-built facilities like we have in the CRF. Moving on to the state-of-the-art facilities, because patients are having additional samples taken, often to look to see how these drugs work or how they're processed by the body, we need additional facilities such as laboratories on site, such as trial-specific pharmacies, and all of that is located within the CRF to enable us to run these studies efficiently. Skilled staff are essential, so we need people who are used to looking after patients as part of clinical trials, and specifically early phase clinical trials. And that is a huge team. So we have our research nurses, we have people working in the laboratories, we obviously have oncology doctors, we have fellows who are on the units, we have radiologists, we have data managers, we have pharmacists. So there's a huge team, and they are very skilled and co-located at the CRF. In terms of academic collaboration, so what the CRF really is, that bridging point between the basic scientists who have an idea in the lab and who have some initial experimental data to suggest that this might be an effective treatment. And then on the other side of that, you've got all the way down the road when a treatment is approved. And in the CRF, we're that bridging step. So we're that first time where the scientists might be coming to us and saying, we've got this new treatment, but we want to be able to see whether this is safe, whether this may be effective in people. So we're really that step and that bench to bedside. And therefore, it's key that we have key collaborations with our academic partners. And obviously, we are part of UCL, ECMC, and we're very fortunate to have the Pears Institute on site as well, who are one of our key collaborators. And then again, just on to equality of access. So as I said, we have a diverse patient population. It's our responsibility to make sure that they are well represented in our trials. And moving on to that, I was just going to show you a very quick video, and we were very fortunate to get some funding from the Royal Free Charity for this, which is a video available in multiple different languages explaining really what a phase 1 study is and what a patient may expect from the study.
This video explains what is meant by a phase 1 clinical trial for cancer, and answers common questions about what is involved before a particular trial that may be suitable for you is discussed in more detail. Clinical trials are medical studies involving people. You may hear your doctor speak of them in terms of phases, phase 1, phase 2, and phase 3. Each phase is a different step in the journey of developing a new treatment for cancer. A phase 1 clinical trial is the first time a new drug, which has shown promise in a laboratory setting, is tested in people, and may be the first and only way to try a new treatment that is not yet generally available. The priority in a phase 1 trial is safety, to find out the best dose that can be given safely without causing too many side effects. Phase 1 trials also test when a new treatment should be given, such as every day, every week, or once every month, and to see whether the new treatment helps stabilize or shrink a cancer. Because these trials are investigating very new treatments, you have an experienced team, which might include specialist doctors, nurses, researchers and data managers, working closely together to look after you. For this reason, Phase 1 trials are usually conducted in specialist units with the necessary expertise at hand, like the NIHR Royal Free Clinical Research Facility. Phase 1 trials usually involve only a few patients at first who receive a low dose of the drug under close supervision. If all goes well, the next few people have a slightly higher dose, and so on with other people until we know the best dose to use. This takes time and means that some patients who are keen to take part may have to wait a little while for an opportunity to join a trial. All patients interested in taking part must complete certain checks to ensure they are eligible. This is called screening and may involve tests such as weight, blood pressure, blood and heart investigations, scans, and sometimes a biopsy of the cancer. It can take a few weeks for the results to come back, when the research team will arrange a meeting. Depending on the results, not everyone who is screened will be able to take part in the trial. For those who go on to receive treatment, there may be more hospital visits than usual, particularly at the start of a trial, sometimes requiring an overnight stay in or near the hospital. Visits often involve extra blood and urine tests, scans, and sometimes biopsies to monitor the effect of treatment. Costs for extra hospital visits are usually reimbursed. Side effects can happen. Questionnaires on how you are feeling are often used. Some questions may not seem relevant to you, but it's important to try and answer them all as honestly as you can. As well as giving you access to a new treatment that would otherwise not be available, taking part also gives you a named research nurse you can see in person or contact at any time with any questions you may have. There is no guarantee that the treatment will work for you, and there is some uncertainty over side effects, which is why participants are monitored so closely. Your doctor will discuss the trial with you and provide a detailed information sheet about the procedures, risks, and potential benefits. Once you've had time to consider this with family and friends and your healthcare team, you will be asked for your written consent to take part. If at any stage you change your mind, consent is yours to withdraw. You can stop the trial at any time by letting the research team know, and this will not affect your general medical care in any way. If at any stage the research team think that a new treatment is not working or that there is a concern over safety, then the trial would be stopped immediately. When patients with cancer are first offered the opportunity to take part in a Phase 1 trial, they are often excited because it offers hope when perhaps other treatments may not have worked. Excitement can lead to anxiety with all the paperwork you are asked to consider. It can become quite daunting. It's normal to be unsure what the best thing to do is at this time. Talk to friends and family and ask anything that matters to you. People who take part in Phase 1 trials often say how amazing it is to be part of a study which could lead to the cancer treatment of tomorrow. As well as providing early access to a treatment not yet available, taking part will also guide treatment for others with cancer in the future. Every drug treatment for cancer that is used today around the world has at some stage been tested in a Phase 1 clinical trial in specialist centres like the Royal Free Clinical Research Facility.
So that, I'm not sure if you caught at the beginning as well. So that is that video is available in 5 languages, and we're hoping to be able to expand that. But that's one of the efforts we're making to really try and explain a bit about what we're trying to do, and to make sure that people from all communities are able to access information about what we're doing, and hopefully therefore improve participation in trials going forwards. So moving on, so again, I will be brief because we don't have lots of time, but essentially I was just going to highlight some of the trials or some of the new ways we're looking at treating cancer, which are actually being taken part at the CRF currently, so are currently open studies. So if we move on, this slide is really just to highlight, most people here, a lot of people here will be familiar with immunotherapy. There's been a lot about it in the press. And immunotherapy is really a new way of treating cancer that has revolutionized often how we manage certain cancers. It hasn't been effective in all cancers, but for a lot of cancers, it has really changed the way that we are managing patients. And the broad way it works is to take the brakes off the immune system. So we're looking really to activate the immune system. So essentially send a signal to it to say, wake up, you're allowing these tumour cells to grow undetected and uncontrolled. And actually you should be recognising that these are foreign tumour cells and you should be killing them off. So that's what we're trying to do. Now, this figure is just very briefly to show you. On the left, we have immunotherapy combinations which are approved for clinical use and which we are using as standard of care. On the right, we know that some patients will either not respond to immunotherapy at all or will initially respond, but then unfortunately go on to have disease progression. And for those group of patients, we're looking at new ways that we can harness the power of the immune system. And so on the right are multiple different combinations which are currently under investigation in cancer clinical trials. And it was just really to highlight that for every combination, every option here on the right, we are actively involved either in conducting the research or the basic science here at the Royal Free Hospital. So to take a bit more of a specific focus on a few studies. So I mentioned before that immunotherapy takes the brakes off the immune system. And normally the way it does that is we have an antibody that targets a specific checkpoint or a specific pathway in the immune system. And it basically blocks that pathway and sends a signal to activate the immune system. So those are the kind of first drugs that were developed that have revolutionized how we treat a lot of cancers. But we're now moving on to the kind of second and third generation of these types of drugs. So this study is a study that we are participating in, where we are looking at patients with hepatocellular or primary liver cancer. And it is looking at a new therapy where instead of having an antibody which can target one pathway in the immune system, it is what we call bispecific antibody, which is capable of targeting two separate pathways. And by doing that, what we're hoping is that actually people who may not have responded to blockade of one pathway are actually then rescued or are able to respond when you have this blockage of two pathways. And there are also other ways in which these antibodies may work, sometimes by physically bringing the immune cells adjacent to the tumour cells to enable them to recognise and kill these tumour cells. And so this is one study that we currently have patients being treated on here at the Royal Free Hospital. If we move on to the next slide. So this, the Grey Wolf or EMIT-1 study, is an early phase study, a phase 1 study. So this is a new treatment that has been developed by scientists in the lab that had previously never been tested in humans. So again, this is working on a kind of immunotherapy basis. We know that your immune cells should recognise cancer cells, but we know that often they don't, and they allow those cancer cells to continue to grow. And one of the reasons we think that may happen is that they're just not recognising these cancer cells. Now, the way the immune system normally works is proteins in a cell, whether they be from cancer or whether they be normal proteins, are taken into a cell and they're chopped up in the factory called the endoplasmic reticulum within the cell. And those proteins are chopped up into various different lengths by a specific enzyme. And then they travel all the way back up to the surface of the cell again, and they kind of sit there waiting to be seen by the immune cells. Now, what we know is often that doesn't really happen, and the immune cells don't seem to see or recognise these cancer cells as cancer. They still think that they're part of a normal body cell. So this study is looking at a new or novel drug which is blocking the effect of that enzyme that chops up these proteins. And by blocking it, what we are hoping is that you then get lots of proteins of various different lengths that then travel and sit at the surface of that cell and make that cell start to look abnormal to an immune system. So essentially, you're trying to get the immune system to say, hold on, this cell looks abnormal, this cell now looks strange. And so this is a study that we are participating here at the Royal Free Hospital. And this was being tested as in the first time in humans, and has also moved on now to be tested in combination with immunotherapy. Moving on. Vaccine studies, we get lots and lots of questions from patients about vaccine studies. There's been lots of things in the press. One of the studies that we are recruiting patients to here, which is my colleague Rob Goldstein is leading on, is this study in colorectal cancer patients. So this is aimed at patients who have had an operation to remove their colorectal cancer. But we know that unfortunately, a proportion of those patients will still at some point go on to get recurrence or relapse of their disease. And so what this study aims to do is to look at whether you can create a vaccine to try and reduce the risk of that happening. So for specific patients, their initial tumour from their surgery is taken and it is sequenced. So we look at the changes in the DNA and then generate a specific vaccine individualized to that specific patient. So each patient who's treated on the study will receive a different vaccine that's personalized to them. And what the study is looking to see is whether that reduces the risk of disease relapse in the future. And then I think finally, yes, we've got the Athena study that is running at the Royal Free at the moment. So this is, again, a novel or a different way of delivering therapies. So traditionally, we have used chemotherapy a lot in cancer treatment, and it can be very effective in specific tumour types. But it's sometimes a little bit of a blunt tool because chemotherapy will have an effect on rapidly dividing tumour cells. But unfortunately, it will also have an effect on normal bystander cells, which is why we get some of those classical side effects that are associated with chemotherapy. What this study is doing is investigating a new drug or new class of drugs called antibody drug conjugates. So in this case, you have an antibody which is capable of recognizing a specific protein. So in this case, an antibody is designed to recognize a protein that we think will be more visible or more expressed on cancer cells as compared to normal body cells. Attached to that antibody is a chemotherapy drug. So the intention is that you deliver the drug into the bloodstream, the antibody goes and only binds to tumour cells, is taken up by those tumour cells, whereby the chemotherapy can then have its effect. So what we're hoping is that it's more effective because you're able to give a higher dose of chemotherapy directly to tumour cells, but also that the side effects are reduced because you're not delivering the same chemotherapy drug to all of the other bystander normal body cells. So this is a study that we are currently taking part in, and we were actually the first site in the UK to recruit a patient to this study, which is a globally recruiting study. So in summary, I think I'm okay for time. So we're really excited about working in the CRF. We have unique facilities and expertise to be able to run these early phase studies, which are potentially higher risk in nature. We are a young-ish unit. We're very excited about the future. We're working hard to increase the number of studies that we have in our unit, but also, as I hope we've shown previously, to try and make sure that our diverse patient population is really able to access all of the studies that we have to offer. And we're in a unique position to do that now because we have Barnet Hospital, Chase Farm, and now North Middlesex Hospital. And that means that we can really increase recruitment to trials and make sure that we are including all the relevant patient populations to make sure that the results of these studies are applicable to our entire population. So I think that was my last slide. So what we're going to do moving on is Glorianne, who is a very talented clinical research fellow, which means that she is a doctor who is undertaking a PhD. And she's going to explain a little bit about the PRIMA-1 study, which is being led at the Royal Free Hospital.
Thanks, Alexa. I'm very excited to be able to talk to you about the PRIMA-1 study. Which is an early phase clinical trial for patients with liver cancer. So if we could just start the next slide. So why is liver cancer of interest to us? Liver cancer is a global health challenge. It is the 6th commonest cancer and the 3rd leading cause of cancer-related deaths worldwide. And it's projected to increase and affect 1 million people each year by the end of 2025, which is now, really. And cancer research data that's been presented by the British Liver Trust shows that where mortality, so deaths from all cancers, is decreasing because of advances in treatment and diagnosis. Unfortunately, the death rate from liver cancer is rapidly rising, which makes it a cancer of unmet need, according to Cancer Research UK. Next slide. In keeping with the rising numbers of patients within the Royal Free Hospital, we've also experienced this increase in patients coming through our clinics. So you can see this is old data, but you can see that actually between 2003 and 2021, there's been a steep rise in the number of patients presenting to us with primary liver cancer. These patients are managed by a multidisciplinary team of surgeons, hepatologists, oncologists, interventional radiologists, and pathologists who all work together to offer expertise to these patients in a joint service. Next slide. So over the years, so here I'm just showing you some of the treatment options that we've had available for patients with advanced liver cancer. These are patients who present at late stages. Unfortunately, these make up 70% of our patients, and for whom curative treatment isn't an option. Unfortunately, chemotherapies don't work for primary liver cancer. And you can see between 2008 and 2017, so almost a decade, we only had one effective treatment available. But there's been an explosion of new therapies in the last few years, particularly since 2020, when it was found that immunotherapy drugs can improve clinical outcomes for patients in terms of survival and also their tumor shrinkage. And you can see at the bottom left here that compared to sorafenib, which is a type of targeted therapy, atezolizumab and bevacizumab, which is an immunotherapy combination, can improve survival for patients with advanced liver cancer. And actually, the Royal Free was involved in the clinical trials that led to these findings, and we're able to give patients, we were one of the first sites to be able to give patients these drugs via an early access medicine scheme. Which is when you're able to, when a drug shows such promise that we're able to offer it to our patients before the formal regulatory approvals have been finalized. Next slide. So these immunotherapy drugs, as Alexa alluded to or explained, tend to work by blocking checkpoint molecules, which are brakes on immune cells that stop the immune cells from being overactive. When an immune cell encounters a tumor, you want the immune cell to be able to kill the tumor cell. And this job is usually done by T cells. And so the current immunotherapy drugs that we have aim to the brakes or remove the brake to enable the T cells to recognize the tumor cells as a cell that shouldn't be there, activate themselves, divide up, and then kill the tumor cells. Another way that these immunotherapy drugs work is also by getting rid of tumor-promoting immune cells, which is a bit counterintuitive, but there are some immune cells whose job it is to make sure that the immune system isn't fully activated all the time. And so these immunotherapy drugs can work by enhancing the activity of T cells or by reducing the activity of tumor-promoting cells. And we know from clinical trial data that when these immunotherapy agents are combined with targeted therapies such as lenvatinib, which I'll talk about later, which help to normalize the vessels within the tumor, that they work together synergistically to improve outcomes for patients. Next slide. And so these advances within the advanced liver cancer or advanced HCC setting have improved outcomes for patients with advanced HCC. But a third, 30% of our patients that we see are diagnosed with early stage disease. And this means that this patient group are usually presenting at this end, so towards the left of the images, where they have either small tumors, few tumors, or tumors that are amenable to potentially curative treatments, such as surgery to remove the tumor, transplantation, or ablation to burn the tumor off. So ideally, these patients should be able to be offered a cure where they don't have to worry about their liver cancer anymore. However, unfortunately, about 70% of these patients will relapse within 5 years, and often relapse with more advanced disease, and sometimes can find themselves in the group that I was describing earlier, where we know that even with our best treatments, the survival is still around 20 months. And so there is an urgent need to be able to try and modify this risk of relapse for these patients with early stage liver cancer, which is where PRIMA-1 comes in. Next slide. So PRIMA-1 trial stands for perioperative pembrolizumab and lenvatinib in HCC, and that's an investigator-led study led by Professor Tim Meyer, who a leading oncologist at the Royal Free Hospital, and who designed and conceived of this study, basically trying to apply the benefits that we have seen in advanced HCC to patients with early stage HCC. So the idea here is that if we give patients with early stage HCC immunotherapy before they have surgery, can we boost their immune system so that even after you've removed the tumor, the immune system is primed and surveilling and making sure that any new tumor cells can be taken care of so that these patients don't relapse. This is a phase 2 study, so it sits in the middle where Alexa explained, where we're trying to confirm the safety of the study of this approach. It's a novel approach called the neoadjuvant trial, which means that we're giving a drug treatment before we offer surgery to these patients. And so far we've opened 10 sites across the UK, which has taken a huge effort and work with collaborations between the Royal Free and UCL. And all of the samples, research samples are processed within UCL as well. Next slide. As I explained, so this is a study where we aim to recruit 60 patients, and we're randomizing patients to receive pembrolizumab. Pembrolizumab is an immunotherapy drug that blocks PD-1, which is one of the known checkpoints that can inhibit the immune system. Patients can either receive that drug on its own, or they can receive lenvatinib, which is a targeted treatment, which helps to normalize the vessels on its own, or they can receive the combination of the two drugs together. And then they receive 2 cycles and then go on to have surgery, and they receive immunotherapy for 12 months after that. The fact that patients can receive either or, either each drug or the combination, will give us a great insight into the contribution of each drug towards modifying patients' risks in the future. And it's the only neoadjuvant study that has actually got all 3 arms within it, and is one of only under 5 such studies in the whole world. Next slide. So the objectives really of the PRIMA-1 study is that it will allow us to be able to compare the efficacy of combination treatment, so where you're combining pembrolizumab and lenvatinib, with pembrolizumab on its own or lenvatinib on its own. And the way that we aim to assess the effectiveness, because as assessing survival would take a long time, is by looking at the tumor that we resect to see how much viable tumor cell is present. And we expect that if a patient, after receiving 2 cycles of therapy, has less than 10% of tumor cells viable, that this is a good outcome, and we define that as major pathological response. And we hypothesize that the combination treatment will result in a higher major pathological response rate than either drug used as a single agent. Next slide. The other really key benefit of this study design, where you are giving systemic treatments before surgery, is that it gives us really unique access that we wouldn't otherwise have to samples to perform experimental translational research. We know that usually immunotherapy only benefits a third of the patients who receive it. But what we don't know is why certain patients benefit and others not, and why some patients after receiving therapy and benefiting eventually lose their benefit. In this study design, we're able to do a biopsy before the patient receives any treatment. And then we have lots of tissue at the time of resection. And then we have multiple time points baked into the trial where patients give blood samples for research. So we're in a unique position to basically look in the blood and in the tumor, both before therapy and on therapy. Next slide. Next slide, please. And because of this unique access of samples, we have designed a unique translational research package led by the Maney Lab at UCL, but collaborating with Professor Benny Chain at UCL and Professor Quaglia, who is a leading pathologist at the Royal Free, to basically use multiple cutting edge techniques to be able to really drill down and have a detailed look at the immune system to see if we can get any indicators of why certain patients respond and others not. So with these, this multiple approach, we'll be able to investigate the immune cells within the tumor, around the tumor, and in the blood. We'll be able to investigate how changes at baseline and on treatment correlate with response. And we'll be able to characterize which T cells are able to do the job of clearing tumors and which ones are less effective at doing the job. Next slide. This will inform us about how the immune system that a patient has at baseline can help predict their responses to therapy. That's important because any treatment that we offer patients has the potential for side effects. And really, we should only be exposing the patients who are most likely to benefit to any therapy, to that therapy. At the moment, we have no way of knowing, but by identifying biomarkers, we'll be able to fully select patients based on whether they're likely to respond or not. It will also give us insight into the mechanisms of how these drugs work. We know that combination therapy works better than single therapy, but we don't fully yet understand why. And then finally, by patients may or may not respond to therapy. We're hoping to identify novel targets and new pathways that we can then bring from the lab into the clinic via the drug development pathways that Alexa mentioned before. Next slide. So here I'll just give you a flavor of some of the data that we've got so far using flow cytometry approach. So in this trial, so in PRIMA-1, we're giving pembrolizumab, which blocks PD-1. And so here I'm just showing you which of the immune cells within a patient's blood express, because for the drug to work, as Alexa mentioned, this is an antibody that is directed against a target, and in this case, directed against PD-1. So what my question for this is, we've got lots of immune cells within a patient. Which of the cells is expressing the highest level of PD-1 and therefore is interacting with the drug? And as expected, it's the T cells that have the highest percentage of PD-1 on them, which means that our pembrolizumab will likely be binding the T cells predominantly. Next slide. So in conclusion, I have explained to you what the PRIMA-1 trial is. It's a multi-center, 3-arm phase 2 clinical trial for patients with resectable HCC. So that's surgery that can be removed. HCC that can be removed by surgery, and it's led by academics at the Royal Free Hospital as well as UCL. That the design of the study in itself is quite novel for HCC, and its design allows us to be able to both improve clinical outcomes for patients potentially, but also to provide a unique source of HCC blood and tissue samples for exploratory research, which we hope will inform biomarker discovery and uncover mechanisms for treatment response and resistance. And that ongoing work will help us to be able to really understand the significance of drug binding to their target T cells and how that might translate into clinical responses for patients. Thank you.
Thank you so much. I think now it's time for our Q&A session, and yeah, let's go to the question, please.
So I've got a list of questions here. I think maybe I'll read them out then. So one of the first questions we have had sent through is, how does the Royal Free London incorporate patient voices and lived experiences when designing and evaluating cancer research studies? So I think I'll answer this. I think everyone agrees now that it is critical to have early patient involvement in clinical trial design. So even now, at the point of the very initial trial proposal or grant application, we have patient steering committees that we would be consulting. Often we would contact charities, so specific tumour type charities, to try and get input from patients in that way. Once you've gone, most funding bodies now will also mandate some kind of patient or public involvement, just really highlighting how important this is. Even once you've got through that phase, when you get to ethics committees, they will have patient representatives. So, I mean, I think we all know there's no point in designing a study and going all the way to having it funded if it's a study that patients either don't want to participate in or who are unable to participate in it. So that's really key, and we think about that now really from the very beginning. The next question I have, which perhaps Glorianne could answer, is how does your partnership with UCL, University College London, help translate research findings into tangible improvements in patient care pathways?
So this is a really great question. So the Royal Free in particular has very, very close links with UCL, and thanks to the Royal Free charity, the Pears Institute has also become a reality which brings the Division of Infection and Immunity into close proximity with clinicians and researchers at the Royal Free Hospital. This has really benefited, and fostered important clinically relevant conversations happening between the scientists who are doing the wet lab research, driven by important clinical questions. My PhD is a true testament to this in terms of Primer 1. I work as a clinician in the HCC clinic, so I see patients on a Monday, consent them to these research projects, but I'm able to communicate to them through data and through some of the exciting ideas that we have in the lab, and through that consent them for research projects. I also then handle the samples on the, in the institutes right next door. And I think that by working closely together, it means that the scientists are putting the effort into trying to address questions that are really meaningful to patients, and which could actually be translatable into clinical practice rather than, other less kind of translatable work. And so I've definitely seen the benefits directly myself for patients and in terms of my own career journey so far.
And then maybe leading on from that as a little bit is, how does the Royal Free London collaborate with other national and international institutions in its cancer research programme? So I think, Glorianne has mentioned a lot of that. We know that collaborative working is essential if we're going to improve the impacts and the efficiency of cancer research programmes. And so we work a lot with colleagues across the UK, but also internationally. So as Glorianne said, a great example of this is the Primer 1 study, where patients are being recruited across multiple NHS hospitals within the UK. The translational work is being done in collaboration with UCL and the Pears. And Glorianne's project at PhD is funded by the Hunter Consortium, which is basically a network that has CR UK funding to try and drive progress in HCC. And so that is a collaboration between 11 centres across the UK, Spain and Italy. So it's a real international effort. The next question is for the promising cancer research underway, what are the estimated timelines for these findings to become standard treatments? And perhaps Glorianne can answer that.
Yeah, another great question. So the reality is that it does take several years to translate exciting clinical findings from the bench to the bedside. As Alexa mentioned in her talk, from preclinical findings, you need then clinical testing via phase 1, 2, and 3 clinical trials. And each of those clinical trials takes a few years to do. And particularly phase 3 trials take several years to complete. And then you need regulatory approval before these treatments become standard of care. But the way that we make sure that our patients at the Royal Free benefit at every stage is that the clinical question at the preclinical level is driven by patient-relevant questions. And then we enroll patients. By enrolling patients into clinical trials, we're giving them access to novel therapies that they wouldn't otherwise have access to in a controlled and safe way. And so some of our patients that I've seen and we see in the HCC clinic are the first to have received some of these drugs that have now become standard of care. And so although it does take several years to get to the point where any idea is a reality, we make sure that we optimize our patients' chances of experiencing the benefits of these treatments all the way through the design of our research till the point when it is available worldwide.
And then just quickly, because we're kind of running out of time, so there's some questions in the Q&A function here. So it says, how is recruitment to target in Primer 1, and is it a non-commercial study? And just in the interest of time, Glorianne, I might just say, so that is an academic study. So it's being recruited in multiple NHS hospitals where HCC patients are identified. And so it is a non-commercial study. It's an academic study led. The chief investigator is Tim Mayer. And so patients should be recruited from their HCC clinics and given information about the study so they consider whether they want to participate. And then what and how long is the research process prior to phase 1 trials commencing? So that really is very variable. So phase 1 is obviously the first time something is tested in a human. The process prior to that is very much dependent on the agent, whether it's a totally novel mechanism, whether it is an adaptation of a previously tested modality. So that can vary. But realistically, we are talking probably several years at a minimum before something is going into a phase 1 study. There is a question here about stomach cancer. That's quite a specific question. We do have studies we are recruiting to trials, including patients with gastric cancers. And I think I direct you towards your treating oncologist, who should be able to give you an idea of what studies are open at the Royal Free, and if not, to liaise with some of the oncologists working here who may have more information. We also work as a network. So sometimes we refer patients, and if we don't have a study available for that person, we consult with our colleagues in neighbouring hospitals and hospitals across the UK as well to see if we can identify studies that may be specific to an individual. We're also running the target study here, whereby patients can have profiling of their tumours taken by withdrawing just a usual blood sample, but we can actually sequence the DNA, and sometimes that can give us information as to whether someone is suitable for a specific clinical trial. I think we may have run out of time for that. So I don't know, Tatiana, if you want to wrap up, but I would just say thanks very much again for the opportunity for talking today. And we do have, if anyone has any other questions, we're very much welcome. If you email them in, we'd be happy to answer them elsewhere.
Yes, thank you so much, and on behalf of our governors, to Alexa and Glorianne for their fascinating presentation tonight. And I think this is really important topic, and I'm so glad we have been able to showcase the amazing work you and your colleagues do for our local communities. And I would also like to say thank you to everyone who joined us this evening. If we were not able to answer your question during the Q&A session, please get in contact with our membership team. The email is on the screen now and has been shared in the chat. And if you missed any of our previous Medicine for Members events, recordings are available to watch on our website. Please also let us know about any future topics you would like us to cover. If you have any feedback about this evening's event or any other events, please again get in touch with our membership team. And if you'd like to contact our Council of Governors, again, you can do it via email. The address is on the screen now, and it has been shared in the chat as well. Once again, thank you for joining tonight, and I hope you had a great evening with us and you enjoy the rest of the evening. Thank you.